Hi, everyone, and welcome. My name is Sarah Sims. We're pleased that you could all join us today for the lecture in Volume 5 of our 12-week No Neuropsychology didactic series that brings you lectures from experts in the field covering different topics each week. The series was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities. We would like to thank our sponsors for their financial support of the series. Before we start, we want to make everyone aware of our YouTube channel. Every No Neuropsychology and No Neuroanatomy lecture is available for your viewing pleasure. Be sure to go check it out, subscribe, and like our lectures. Here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now it's my pleasure to introduce Dr. Armstrong for today's lecture on Lewy body dementia. Dr. Armstrong is an associate professor of neurology and the director of University of Florida Dorothy Mangurian Clinical Research Headquarters for Lewy body dementia, a Lewy Body Dementia Association Research Center of Excellence. Her research focuses on the lived experiences of individuals with Lewy body dementia and their caregivers, including communication between people living with LBD, families, and clinicians, improving diagnosis and prognosis, and improving end-of-life care. It's a pleasure to have you today, Dr. Armstrong. Go ahead and take it away.
Thank you so much. All right. So today I am going to give you an introduction to Lewy body dementia. And really, when we start with Lewy body dementia, I think it can be helpful to start by discussing Parkinson's disease. And in just a moment, we'll talk about the relationship. Now, this isn't going to be a talk about Parkinson's disease per se, but we'll spend a few slides on Parkinson's disease and then talk about how that is part of the broader concept of Lewy body dementia. So when we think about Parkinson's disease, we usually think about a neurologic disorder that starts with physical manifestations. It often starts in a person's 60s, but it has a really wide standard deviation. So 50s to 70s is very common, and it gets more common as people get older. That being said, we do see people with young onset Parkinson's disease in their 30s and 40s, but I would say 50s to 70s is the range that we see most commonly in clinic. Now, when we think about Parkinson's disease and when you learn about it in medical school, we usually think about it starting asymmetric, so more on one side of the body, often starting with that characteristic resting or pill rolling tremor with slowness and stiffness on one side of the body. And that is the classic presentation, but there are other motor presentations as well. For example, you don't need a tremor to have Parkinson's disease. It can also start symmetrically on both sides of the body. And recent research suggests that there might be different phenotypes of Parkinson's disease as are displayed here. So there's a mild motor predominant form of Parkinson's disease, which tends to happen in people who are a little younger, starts with that classic tremor, often asymmetric, very much motor features with a great response to medication and a mild progression over time. We now know there's also a severe phenotype of Parkinson's disease, this diffuse malignant Parkinson's disease, where it tends to be symmetric. There's a lot of physical disability early, but there are also early non-motor symptoms like mild cognitive impairment, REM sleep behavior disorder, orthostasis. And these people may not respond well to medication and have a quicker progression. And then there's this intermediate phenotype where it's still mostly motor at the beginning. As they progress over time, they need more medication. They have a decent response to medication, and they have some of the ups and downs that we can see with medication. When we think of diagnosing Parkinson's disease, these formal criteria that were updated in 2015 say that to have Parkinson's disease, you have to have bradykinesia. And that's slowness, but not just slowness. It's when you start kind of big and slow, but you get smaller over time. So it's slow and decrement. And then you need either rigidity or tremor. People with Parkinson's disease usually have a clear and dramatic response to dopamine therapy. They can get levodopa-induced dyskinesias, where you kind of get the wigglies as you go along. And many, but not all, have that rest tremor on examination. And then it's also supportive if they have loss of smell. And in the criteria, they mention MIBG scintigraphy, but in the United States, we don't have this test available to us. And then in these diagnostic criteria, there are also some absolute exclusion criteria that would make you think of other diseases, and some red flags which don't rule out Parkinson's disease, but make it a little bit less likely. So even though we've classically over many years thought of Parkinson's disease as a motor disease, we know that there is clearly cognitive impairment associated with Parkinson's disease. And the risk of cognitive impairment in Parkinson's disease increases with disease duration, how long you've had the Parkinson's disease, and how old you are. So the longer you've had it, the more likely you are to have cognitive impairment, and the older you are, the more likely you are to have cognitive impairment. And when we think about cognitive impairment in Parkinson's disease, we have the same categories of cognitive impairment that you would also see in other scenarios. So we have mild cognitive impairment and we have dementia. Now, mild cognitive impairment is probably present in, on average, 30 to 40% of people at the time of diagnosis in Parkinson's disease. So that mild cognitive impairment can be there right up front. But we also know, as I mentioned, that the likelihood of some type of cognitive impairment in Parkinson's disease increases with time. So when we think about Parkinson's disease dementia, it's estimated that about a quarter to 30% of people with Parkinson's kind of at any time will have dementia. And in the Sydney study that followed people with Parkinson's over time, they found that if you were living with Parkinson's disease at 15 years, 36% of those people had MCI, and almost half had PD dementia. And in people with Parkinson's disease who lived with the disease for 20 years, 83% met criteria for PD dementia. So if you live long enough with Parkinson's disease, you're almost certain to have some degree of cognitive impairment. And for this reason, the American Academy of Neurology recommends that people with Parkinson's disease have cognitive screening at least once a year, because we know that this is part of the presentation and part of the experience of Parkinson's disease. Now, I told you that we were going to start with Parkinson's disease, but we were going to come to the topic of Lewy body dementia. And you can see from this slide that it's challenging to think about the vocabulary of Lewy body dementia because there are so many umbrella terms in this field. So if we come at this from the lens of Parkinson's disease or from movement disorders, Parkinsonism, we have Parkinsonism as the first umbrella term. And there are many kinds of Parkinsonisms. There's vascular Parkinsonism, there's drug-induced Parkinsonism. We have tauopathies like cortical basal and progressive supranuclear palsy. But then under this Parkinsonism umbrella, we also have the umbrella of synucleinopathies. And there are a number of synucleinopathies. Parkinson's disease is the most common, but multiple system atrophy and dementia with Lewy bodies are also synucleinopathies. So under that synucleinopathy umbrella, we now have this umbrella of Lewy body dementia. And Lewy body dementia is a term that encompasses two clinical diagnoses: Parkinson's disease dementia and dementia with Lewy bodies. And we can also think about umbrella terms starting with the umbrella term of dementia. So if we think of dementia as our starting point, we think about Alzheimer's disease dementia as the most common dementia. Lewy body dementia would be the second most common neurodegenerative dementia. but vascular cognitive impairment is probably the second most common cause of cognitive impairment overall. And of course, there's more and more research to show that many of our dementias are actually intermixed. Multiple pathologies are common, but if we're just trying to break it down by single diagnoses, we think about Alzheimer's disease dementia being the most common. So there are a lot of different umbrella terms. But the vocabulary here is really important. And so I do want to take a moment and pause and really think hard and talk about these terms. So as you just saw, Lewy body dementia is the umbrella term, including clinically diagnosed dementia with Lewy bodies and Parkinson disease dementia. Now we're going to dig into these a little bit more, but dementia with Lewy bodies, as classically defined, would be diagnosed when a person has dementia that occurs before or concurrently with Parkinsonism, or within 1 year of onset of motor symptoms. Now that being said, you do not have to have Parkinsonism to have a DLB diagnosis, and there are a number of core features that we'll review in a moment. As classically defined, Parkinson disease dementia is diagnosed when a person has an established diagnosis of Parkinson disease with those motor features, who develops dementia over a year after they were first diagnosed. And Lewy body disease is a pathologic diagnosis that we can only see on autopsy. So let's spend a moment about the pathology. We're just going to do this quickly, but I mentioned on an earlier slide about synucleinopathies. So the synucleinopathies are the diseases associated with the clumps of the protein alpha-synuclein. We don't know what alpha-synuclein does for normal function, but when it clumps, we see these Lewy bodies that can only be seen on autopsy. Right now, we don't have any biomarker that reliably distinguishes these. There's no PET scan, for example, to show Lewy bodies. There are a couple of biomarkers that might be a little close. They're looking at CSF for synuclein now and skin biopsy for synuclein. Both of those have some provisional FDA approvals, but they're not yet used in routine practice. So right now, we don't have a routine biomarker that can show Lewy bodies or abnormal alpha-synuclein in clinical practice, though it may be coming. As I mentioned earlier, the synucleinopathies are Parkinson disease with or without cognitive impairment, dementia with Lewy bodies, multiple system atrophy, and then one we don't talk about too much is something called pure autonomic failure. And they share many risk factors, so age, genetics, male gender, head injury, and certain exposures. And there may be some shared protective factors. Caffeine, strangely enough, smoking might be protective, and exercise. And when we think about the Lewy body diseases, we have in this kind of oval here, you'll see we have both Parkinson disease and dementia with Lewy bodies. So classically, we think about the Parkinson motor syndrome as being Lewy bodies in the brainstem. When those spread more diffusely is when we think we see the Parkinson disease dementia. Similarly, dementia with Lewy bodies has that more diffuse Lewy body appearance on pathology, but you can also see dementia with Lewy bodies with amyloid plaques. So there's a lot of overlap, particularly between DLB and the amyloidopathies. Recent research suggests that over half of people with probable clinical DLB will have elevated amyloid on amyloid PET scans. You can also see some amyloid overlap in Parkinson disease dementia, but it's more common in DLB. So you may be thinking right now, look, that vocabulary is a hot mess. Dementia with Lewy bodies, Lewy body dementia, they're different, PD dementia, like this is a mess. Does this really matter? And my answer to you is an unequivocal yes. And to make this point, I want to tell you about a patient who I see in my clinic. So he is a CEO. I think I was his fifth opinion, and he came to me with a diagnosis of Lewy body dementia. And when I met him for the first time, I was trying to figure this out, and he had some mild cognitive changes. He noticed, he hadn't been working quite as well at work. Names were a little harder to come by at social gatherings. He noticed that when he was exercising, he was getting lightheaded and sometimes passing out. And when he slept at night, his wife told him that he was acting out his dreams and sometimes hitting her. Because he was concerned, he went for an executive physical, and they noticed he was a little slower and he had these cognitive complaints. And so he got what he told me was a diagnosis of Lewy body dementia. We did neuropsychological testing, and he just barely had a little executive dysfunction. And when we rechecked him a year later, he scored normal on all those tests, but still a little bit weaker in the executive domains. He had a history suggestive of REM sleep behavior disorder with the acting out of dreams. He had exercise-induced orthostatic hypotension, and he was a smidge slow, but when I saw him for the first time, it wasn't even sufficient to make a diagnosis of Parkinson disease. Well, there was no way this man could meet criteria for Lewy body dementia. He barely met criteria for mild cognitive impairment in the executive domain. And at that time, he also didn't meet physical criteria for Parkinson disease. But he pretty clearly had a synucleinopathy because he had orthostatic hypotension, he had REM sleep behavior disorder, subtle executive changes, subtle Parkinsonism. And so I told him that I agreed that I thought he had something in the synuclein family, but he really didn't meet criteria for Lewy body dementia. And I've now followed him for 5 years. He now meets physical criteria for Parkinson disease. He gradually, more convincingly met criteria for executive mild cognitive impairment, and his cognition has continued to progress over time. But even 5 years after his initial presentation to me, he was still in that mild cognitive impairment category. And he came to me and said, "Why did they do this to me? I gave up everything." He wrote an open letter to his colleagues and the people he worked with. He stepped down from his job. He retired. He thought he was doing everything right because he wanted to be honest about this Lewy body dementia diagnosis. And yet, even now, 5 years later, he doesn't meet criteria for Lewy body dementia. And I went back to his old records because I was a little confused by this too. What had happened? And I saw that one of his early notes mentioned that he had Lewy body disease. And so I can only think that either they said Lewy body disease and he heard Lewy body dementia, or they used the terms imprecisely because he did have some cognitive complaints. But this is a really good example about how the terms that we use matter, and also how we explain things matter, because he thought that he should give up this job that he loved. And at least at that time, it was probably unnecessary. So the terms are a mess, the vocabulary is a mess, but the words that we use matter. So when we think about Lewy body dementia, we're going to move on now to some of the symptoms that we see in people with Lewy body dementia. And there's a lot of overlap in the symptoms between dementia with Lewy bodies and Parkinson disease dementia. So in dementia with Lewy bodies, we see these memory and thinking problems from the very beginning. They can have early fluctuations, early visual hallucinations. They can, but they don't have to have Parkinson-like movement problems. And they often have prominent autonomic problems like low blood pressure, orthostatic hypotension, urinary symptoms, and constipation. Now, in Parkinson disease dementia, these people usually have years of Parkinson motor symptoms before the onset of cognitive impairment, particularly dementia. They may have gone through many medication trials over the years. They may be more disabled from their movement problems as the cognitive problems develop. The memory and thinking problems occur later in the disease course with or without fluctuations. They may or may not have visual hallucinations or autonomic symptoms, but there's a lot of overlap in these two clinical syndromes. So when we think about the neuropsychological profile in Lewy body dementia, I'm not going to go into this in great depth. I think you would be better served by a neuropsychologist, but briefly, we really see executive function as the most commonly affected. Attention is commonly affected, so are visual spatial and visual constructional functions. Memory retrieval is common, so usually in Parkinson disease, the memory deficits will improve with cueing, and language is rarely affected, at least in kind of that in-depth assessment you have in neuropsychological testing. It's very common for people with Parkinson disease or dementia with Lewy bodies to describe a tip of the tongue phenomenon, where they know what they want to say, but they have a little trouble getting it out, and then it comes to them later. But language dysfunction is not a primary finding for most people with the Lewy body dementias. Now, when we think of this, it obviously has a lot of implications for our cognitive screening that we might do in clinic. And so there's quite a bit of research now comparing the mini mental state examination to the MoCA for people, particularly most of the research was done in Parkinson disease rather than dementia with Lewy bodies. And pretty much all of those studies show that the MoCA is superior for screening purposes than the mini mental state examination. And that's not really a big surprise when we think about domain impairments. If we think about executive and visual spatial function on the mini mental, you pretty much have the intersecting pentagons, and those things are assessed much more thoroughly on the MoCA. And in fact, there was a study published a number of years ago now that was looking for the optimal cutoff score to diagnose mild cognitive impairment in Parkinson disease using the mini mental, the MoCA, or a separate instrument called the Scopa-Cog. And the optimal screening cutoff for PDMCI on the mini mental was 29. Well, obviously that's no good, because pretty much anyone could score a 29 on the mini mental just by being off on the date. So it's not a great screening instrument because it doesn't have a lot of that visual spatial executive testing that you might want to dig into in Parkinson disease. Now, this is not to say that the MoCA is the perfect test. We know that MoCA is very dependent on education, probably more than just that +1 if you have a high school education or less. We know that there are also socioeconomic and cultural backgrounds that may affect how someone performs on the MoCA. So the MoCA is not a perfect test, but it's a better screening instrument in the Lewy body diseases than the MSSE. There are some others that may be okay as well. There's a Parkinson cognitive rating scale that could be used. But the MoCA is probably the most commonly used instrument for cognitive screening in these diseases. So when we think about other symptoms that are common in the Lewy body dementias, fluctuations is a very common symptom. So it's fluctuating attention, fluctuating concentration. Families will sometimes say, oh, there are times where he is just so confused, and then there are times where he's like his normal self. It can also manifest by unexplained episodes of confusion or decreased responsiveness. I have people come to me and they've been told they have absence seizures, which is really a pediatric diagnosis, but it reflects the staring spells that they see these people have. Families sometimes describe it as nobody's home episodes, where people are just kind of staring out there and it's like, hello, anybody home? And there are scales that can be used to assess this. The Mayo Fluctuation Scale is probably the most common one, and it assesses things relating to both fluctuations and things like excessive daytime sleepiness. Now, this has pretty profound implications for neuropsychology, because what you will find on your testing can really vary depending on where someone is in a fluctuation. And we demonstrated this in a recent publication about the challenges of clinical trials in people with dementia with Lewy bodies. Because you can imagine with these fluctuations, it can be really hard to know if someone is improving, worsening, or if we're just capturing their fluctuations. So if you see here, if you test them kind of at a lowish point, Here at time 1, the gradual trajectory is going to be one of decline. But if then you test them at a peak moment when they look really good on their second testing, it's going to be like, well, wow, they got better. Wow, this experimental medication worked. Or if you test them at a low point in their fluctuations, wow, they're a lot worse. Or wow, the medication really isn't doing anything. And so fluctuations have a lot of implications for how you interpret your testing in the Lewy body diseases. And it can be important to ask, the family and informants, like, is this a good period or a bad period? So that you can incorporate that into your assessment. People with the Lewy body diseases can have behavioral and neuropsychiatric changes. So commonly this manifests as formed visual hallucinations. People see cats, dogs, people, but psychosis is a spectrum. So there can also be illusions where there's an actual stimulus, but the brain misunderstands it. So maybe they think someone is walking by them and then they turn and it's a tree in their peripheral vision, or they think they see someone in their room at night, but then they turn on the light and it's a robe. So that would be an illusion. People can have a sense of presence where they really think someone is in there with them in the room, but then they look around and they don't see anyone. Or a sense of passage where they feel like someone is passing by, but there's no one actually there. And then you can have other kinds of hallucinations, auditory, where they hear something, tactile, where they feel like something is touching them, gustatory, but the visual are the most common. There are also delusions where people believe something firmly and nothing you tell them will dissuade them. There are some more common delusions. So spousal infidelity is a really common delusion. Thinking someone is stealing from you is a common delusion. And then there are some funnier ones that have names like Capgras syndrome, probably being the most famous, which is a delusional belief that a person has been replaced by an imposter. So you're not my real wife, you're the other wife, you're the pretend wife, you're Mrs. Smith number 2. Or sometimes it can also be a house. This isn't my real house. This is a fake house. And you can imagine that a lot of these delusions are really devastating to the spouse or the caregivers who are pouring so much into the person with Lewy body dementia, but they're being met with suspicion. And then depression, anxiety, and apathy are really common, both in Parkinson disease and Parkinson disease dementia and in dementia with Lewy bodies. Sleep changes are very common in these diseases as well. So we're going to come back again to the REM sleep behavior disorder where people act out their dreams. Also, excessive daytime sleepiness is very common. And then in dementia with Lewy bodies, they can have Parkinson-like motor symptoms, and obviously those are present in people who start with Parkinson disease. Tremor, it might be a little bit less common in DLB than it is in Parkinson disease, but you can get tremor in DLB as well as stiffness, slowness, shuffling, balance problems, falls, and postural changes. So when we think about the Dlb diagnostic criteria, you don't need to read this whole slide. I'm going to point out the important things. The first thing it starts with is dementia. So hearkening back to that story I told you, you cannot meet criteria for DLB without having dementia. Now, in a moment, we'll talk about the prodromal criteria for DLB, which include a mild cognitive impairment onset form. But for DLB, you have to have dementia. And usually the early and prominent deficits are attention, executive function, and visual perceptual ability. Then to meet probable DLB criteria, you need 2 or more core clinical features with or without indicative biomarkers, or 1 core feature and 1 indicative biomarker. And for possible DLB, you only need 1 core feature or 1 biomarker. Now, the core clinical features are what I've mentioned to you: fluctuating cognition, recurrent visual hallucinations that are usually well-formed and detailed, REM sleep behavior disorder, and Parkinsonism. And then the indicative biomarkers our DAT scan, the MIBG myocardial scintigraphy that we can't get for this purpose in the US, and then polysomnographic confirmation of REM sleep without atonia that goes along with the RBD symptoms. Now you'll notice that there are a number of supportive clinical features, and the supportive clinical features do not play into the formal diagnosis of DLB. But if they're present, you're going to feel even more certain about your diagnosis. And these are things that we ask about in the clinical setting. Have they had severe sensitivity to an antipsychotic agent? Do they have postural instability, repeated falls, syncope, or these episodes of unresponsiveness? Severe autonomic dysfunction, whether it be constipation, the orthostasis, or urinary incontinence, excessive daytime sleepiness, poor smell, hallucinations that aren't visual, delusions, or apathy, anxiety, and depression. Now, I do want to point out a few common pitfalls with these criteria. So the first one is what I already mentioned. You have to have dementia to meet criteria for DLB. Secondly, when you assess REM sleep behavior disorder clinically, you really want to make sure that you're digging in on this or that you're using a validated scale. So it is not enough that someone talks in their sleep or even shouts. It's not enough that someone is a little restless. This is really going to be more diagnostic if they are making a clear movement in their sleep. And if they wake up, they can tell you what they're dreaming and it matches. So they look like they're bicycling, you wake them up and they said, oh, I was dreaming about bicycling. Or they're, hitting their bed partner and they wake them up and they said, oh, I was in a fight. So a clear movement that matches a dream, and also injury for either the person or the bed partner makes it more diagnostic. Has the spouse gotten a black eye? Has the person fallen out of bed and hit their head on the end table? Those things are going to make you more convinced that this is a kind of a more diagnostic RBD. And then it should be noted that hallucinations are not required and Parkinsonism is not required. So I've seen some people who haven't gotten a DLB diagnosis because they don't hallucinate. Well, you don't have to have hallucinations to meet the DLB criteria. And sometimes those are something that happen later. So you only need 2 of the core clinical features if there's no indicative biomarker to meet criteria for DLB. Now, there are people in recent years who are advocating smushing DLB together with Parkinson's disease. So they argue, well, look, the pathology of the Lewy body disease is really pretty similar between PD dementia, and DLB. So there's a little argument about whether there are some nuances, but you can't really tell on pathology if it was Parkinson's disease, dementia, or DLB by looking at the brain alone. And they also point out what we discussed. There's a lot of overlapping clinical features. So they say, well, why wouldn't we just collapse all of these and call them all Parkinson's disease? Do we even need this idea of DLB? And I'll tell you that I'm a splitter. So I'm a splitter because I, as you heard earlier, I work with patients in clinic. I do a lot about communication, helping people live with disease better. And one important thing about living with disease better is knowing what is coming. And there are vastly different experiences between DLB and especially some of the forms of Parkinson's disease. So earlier in the talk, I mentioned a few phenotypes to you. So if we look here and we think about the Parkinson mild motor subtype, they live on average 20 years with a standard deviation of almost 8 years. And it's over 14 years on average before they reach the first milestone of regular falls, wheelchair dependence, dementia, or nursing home placement. And I should mention that many people with Parkinson die before reaching these milestones. But if you're going to reach these milestones in the mild motor subtype, it's on average 14 years. And when I say die, I mean from other things, heart attack, cancer, stroke, all the normal stuff of aging. If we think of the PD intermediate subtype, they live on average 13 years with a standard deviation of almost 7 years. And it's over 8 years till they meet that first milestone on average. The diffuse malignant subtype is the worst subtype. but they still live on average 8 years with a standard deviation of over 5 years. And it's about 3.5 years till they meet that first milestone. And in dementia with Lewy bodies, they've already hit that first milestone because they have dementia, and they live a median of 3 to 4 years post-diagnosis. So I'm really a splitter because when we think about Parkinson's disease and DLB, they really have different experiences in their day-to-day life, how it started, what's causing disability, and they certainly have differences in prognosis. Now, one of the things we've talked about is that there is a lot of overlap between the synucleinopathies. So Parkinson's disease, dementia with Lewy bodies, and MSA, they all have Parkinsonism. They all have autonomic symptoms, and all three can have autonomic symptoms at presentation. They all have REM sleep behavior disorder. And then there are other overlaps too. So PD and DLB, they can have rest tremor, they can have asymmetry or not, they can have cognitive impairment. DLB and MSA, they can be symmetric. They both have more rapid presentation. They both have early severe autonomic failure. They both have early postural instability and falls. And so sometimes it can be very difficult early in the disease to know where someone fits among the synucleinopathies. And it's not just the features you see in clinic, but the prodromal features also overlap. So there are now diagnostic criteria for prodromal PD and prodromal dementia with Lewy bodies. And I'm not going to belabor this, but you can see they're almost exactly the same. They both can have REM sleep behavior disorder, abnormal DAT, subthreshold Parkinsonism, autonomic changes. And so many of these prodromal features are prodromal features for synucleinopathies rather than being specific to one diagnosis. Now, research criteria for the diagnosis of prodromal DLB were published in 2020, and there are 3 proposed presentations of prodromal DLB. The mild cognitive impairment onset form is the best described, and then there's also a delirium onset form and a psychiatric onset form. And they only offered formal diagnostic criteria for prodromal Lewy body MCI because the other 2 prodromal forms aren't well defined enough yet to have formal diagnostic criteria. The main thing to notice about these diagnostic criteria is that they're essentially the same as the DLB criteria, except instead of dementia, the required criteria are the criteria for mild cognitive impairment. But most of the rest, like the core clinical features, are the same. The one caveat is that we don't really know how useful the biomarkers are yet for this MCI form of DLB, just because this is so new, there hasn't been a lot of research in that setting. Now, when we think about the mild cognitive impairment form of DLB, it's really a non-amnestic MCI. And there are a few different studies now looking at this. I've cited 2 of the more commonly cited here. So in an early study out of the Mayo Clinic group, they looked at MCI that progressed to probable DLB. Almost 90% had baseline attention or visual spatial deficits. 80% had probable RBD. Over 40% had clear fluctuations. And the mean Parkinson motor score was 5, which is really low, but suggests they may have had subtle Parkinsonism. And in a totally different cohort, they looked at people who developed DLB or Alzheimer's disease, and then they looked back at the MCI stages, and it mimics that Mayo study very closely. So the DLB MCI group performed significantly worse on visual spatial function and letter fluency tests. They were better on episodic memory compared to AD MCI. They had a higher mean Parkinson motor score. They were more likely to have REM sleep behavior disorder, and they were more likely to have fluctuating cognition. So to pull that together, in the prodromal period between PD and DLB, we have shared symptoms of REM sleep behavior disorder, autonomic symptoms, hyposmia, and non-amnestic MCI. If there's then a motor onset with Parkinsonism, the slowness, the stiffness, the tremor that responds to dopamine with or without MCI, we give them a diagnosis of PD. And then over time, they commonly go on to develop PD dementia. Whereas if they have a predominant dementia onset, we would give them the diagnosis of DLB, and they're separated by this 1-year rule, which is by all accounts completely arbitrary, but they had to pick something, and 1 year is what they picked in the 1990s when DLB was first described. They have common physical, cognitive, behavioral, and other features, so there's certainly a lot of overlap. I'm going to very briefly just comment on treatment. I know this isn't a major issue for you, but for DLB, there are no FDA-approved treatments. There are obviously FDA-approved treatments for Parkinson's disease. We usually treat the Parkinsonism with levodopa. All the other Parkinson medications have a much higher risk of causing side effects like worsened hallucinations, so we usually avoid them. We treat cognition with cholinesterase inhibitors, and rivastigmine is FDA approved for Parkinson's disease dementia. Memantine is controversial. You'll see people who use it and people who don't. And then it's very important to treat the other symptoms: depression, anxiety, sleep, REM sleep behavior disorder, orthostasis, the GU symptoms. When we think about treating hallucinations, we stop contributing medications first, address any underlying illnesses. Cholinesterase inhibitors are not FDA approved for hallucinations, but there is some data and meta-analyses suggesting they may help, so I often try those. We obviously try behavioral and non-pharmacologic approaches, and then if we need antipsychotics, the 3 considered safest are quetiapine, clozapine, and pimavanserin. Pimavanserin is the only one FDA approved for this, and it's only FDA approved in PD psychosis, and technically PD psychosis without dementia. I just want to very briefly mention that there have been a lot of failed clinical trials in dementia with Lewy bodies lately, but there was one that has been reported at meetings but not yet published in press of naflamipod that looked promising. So keep your eyes out for this and know your patients may be asking about it, but the next step is a phase 3 study, so it's not coming to market anytime soon. And then we use a lot of non-pharmacologic treatment approaches. So therapy, PT, OT, speech, swallow, social support, support groups, caregiver training. I connect people with the Lewy Body Dementia Association and the Alzheimer's Association. And then I just want to close with what people want to know. So when you give them a diagnosis, and now we're going to be talking about dementia with Lewy bodies specifically, they come to you and say, okay, you diagnosed me with DLB, what's going to happen? Well, there really wasn't a lot of research on this. And so we did a survey through the LBDA of people who had a family member who died with DLB. And what we found was that from diagnosis to death, the median was 3 to 4 years. Now I have a lot of people tell me like, that seems really short, is that right? But the literature is completely consistent. And every study that looks at a clinical cohort, so a clinical diagnosis of DLB, the median is 3 to 4 years. And it's a wide range. So some people have a rapidly progressive form where they progress from diagnosis to death in less than a year. That's 10%. And then some people live with the disease for over 10 years. So it's a very wide range. We know that diagnosis is delayed in DLB. So unsurprisingly, the time from symptom onset to death is a median of 5 to 6 years. And that reflects those diagnostic delays. The cause of death in DLB is most commonly DLB or failure to thrive. They stop eating, they stop drinking, they stop getting up, they stop talking. In the UK, they call it the dwindles. They just kind of fade. And that probably is in part due to swallowing problems, and pneumonia or aspiration specifically was the #2 cause of death. There was some overlap in what people reported. 20% reported a medical condition and 10% a fall or complications for a fall. So you can see that the top causes of death in people with DLB, and this is totally different from Parkinson's disease. In DLB, most of the causes of death are disease related. Our family said that physicians rarely discussed what to expect at the end of life, and when they did, it often wasn't helpful. The caregiver usually had to ask. And death was usually expected, but fewer than half of survey respondents felt prepared for what to expect. Surprisingly, 80% almost used hospice, but a lot of the time it was just for less than a week, which really isn't enough. The median, though, was 1 to 2 months. And so I just want to conclude with this last slide, because I do feel that sometimes people say, well, there's nothing we can do. We can't stop it. We can't slow it down. What's the use? And I saw a patient who flew to see me with his husband. He had been given a diagnosis of something in the Parkinson family, but not a firm diagnosis. And as I talked to them, I really got the impression from the history and exam that this person had dementia with Lewy bodies. And based on his age, he was an older gentleman, some of his comorbidities. They asked me, well, okay, you think he has DLB, what's coming next? And based on those things, I thought that he had 6 to 18 months to live after I evaluated him. And I told them that. And, we talked about what to expect and why I thought it was 6 to 18 months. And they told me later that when they flew home that day, it was the best day of their lives, because they finally had an answer for what was going on. They could finally stop going to other consultations. They were scheduled at another hospital next week. They canceled it because they had an answer, and they could get on with the business of living. And when he died, almost 12 months to the day after I first met him, it was exactly how he wanted it to be. He was at home with his husband and his dogs at his side with hospice care, and it was really beautiful. And they said that that last 12 months, they had really focused on what was important to them. They spent more time together, they reflected, and they felt it was really meaningful. So even though right now we can't cure the Lewy body dementias, we can really give our patients and their families an answer and give them the ability to do what they want with the time they have left. So thank you very much. I'm going to stop sharing and we'll use the rest of the time for questions.
Thank you so much. Yeah, we do have a few questions, so I'll go ahead and dive right into them. All right, so one of our questions is related to what you talked about at the beginning with conversion from MCI. And so how long after a diagnosis of MCI, which kind of may end up turning into LBD over time, how often should they be assessed?
That's a great question. And the honest answer is we don't know. If we think about DLB MCI or MCI Lewy body, that is a pretty new concept that's been formalized, and there is not a good answer for when we expect it to progress to DLB. There are a couple studies preliminary looking at that, and it suggests that the average might be about 3 years. In Parkinson Disease MCI, that is also still being studied. When does it convert to PD dementia? And those studies that have been done have been a pretty wide range. And that might reflect in part the fact that we might be catching people at different stages of their MCI. So there are people with it's been a bit quicker, 2 or 3 years, but then there are also people who have been in the PD MCI stage for longer. I would say that unlike amnestic MCI, where people may, improve back to normal cognition or may stay at that, it's that 15% conversion over 2 years. These are people in Parkinson's disease who we know have a neurodegeneration, and it will always get worse. So just like we know that the physical will always get worse, I counsel people that we expect their cognition to get worse because we know they have a progressive disease, but the rate at which it gets worse is really variable from person to person, and we don't have a great sense yet for the research. So I don't overly counsel with numbers yet, but I do tell them that I expect it to gradually get worse with time.
Okay, and we actually had a question about the DLB and PDD differentiation as well. So you discussed how they should or should not be considered one disease. So their question was, how does the treatment differ between the two conditions?
Great question. So I'm going to answer kind of with two things. So one, I will say at meetings, this is something that's debated vigorously. So you definitely have a camp who says you should just collapse them, and you have a camp that says they're closely related, but they're splitters. So this is something on which there's not consensus, and there are very esteemed names on both sides. From a treatment perspective, it doesn't really differ between the two because we're treating symptoms. The main difference would be that we have more FDA-approved treatments for PUD dementia. And so for things that have insurance approvals, they can be easier to get, like pimavanserin. I can only usually get in Parkinson disease because it is specifically approved for Parkinson disease. And if it's someone with a DLB label without Parkinsonism, so you can't even fudge it, it is extremely difficult, if not impossible, to get them pimavanserin because it's such a new drug and it's outside the approval. But since we're treating symptoms, we would really treat them pretty identically because the same medicine that will be safe for one will be safe for another, and one that will be dangerous, one will be dangerous for the other. And so the treatment is pretty much the same.
Okay, yeah, insurance can definitely cause some issues when you want to prescribe medications for sure. Speaking of medications, so is there a reason that a provider would change from one, the Carbidopa, Levodopa to another?
So when we think about treating motor symptoms of Parkinson disease, there are a number of different families of medications we can use. So we've got Carbidopa, Levodopa, which has a few different forms. We have things like dopamine agonists. We have MAOB inhibitors. We have COMT inhibitors. We have amantadine. And so the first thing I really focus on is Carbidopa, Levodopa monotherapy most of the time, because dopamine agonists and amantadine in particular have a higher risk of hallucinations, a higher risk of orthostasis. And so in DLB, I usually don't start those medications, and people with Parkinson who might already be on those medications, I gradually start getting rid of them, thinking that they might be causing adverse effects. With Carbidopa, Levodopa, there are three main forms. So there's our immediate release Carbidopa, Levodopa. There's the classic controlled release Carbidopa, Levodopa that's been around forever. And then there's a newer one that's still brand name only called Retari, which is part immediate release and part a new controlled release version together in one capsule. I typically use immediate release Carbidopa, Levodopa. It's the most reliable. It has good bioavailability. It kicks in reliably. And so that kind of is our most effective of the Carbidopa, Levodopa forms. The controlled release version, I will typically use at night. If I want it to be a little bit longer acting, it's still dosed multiple times a day, so it doesn't really save you dosages. I'll use it overnight to help them with a little bit of a longer acting, but I tend not to use it in the day because it only has about 75% bioavailability and it's a little erratic. Sometimes it kicks in quite right away. Sometimes there's a delay. None of us need erratic with our dosing. But if someone has side effects like nausea, sometimes the controlled release works a little bit better from that perspective because it doesn't have as high of a peak. It peaks gradually because it is controlled release. And then the Retari we use in people mostly who have ups and downs, the motor fluctuations. It's useful for some people, but it can be a little bit of a rocky transition. It's dosed completely differently. The conversion table is only right about half the time, but sometimes it's too high or too low, and it can be very expensive since it's brand name only. So I do have some people who use it, but it's not my first line.
That makes sense. Great. Thank you for going over that. As far as the non-pharmacological treatments, someone wanted to know, is CBT a good treatment for hallucinations in DLB?
So I'll tell you, I don't know the data on that specifically. So I have a lot of trouble getting CBT for my patients. They don't have access to it either because there aren't enough providers, or they don't have insurance coverage. And so I haven't had a lot of success just in general getting access to my patients for CBT. when we think about non-pharmacologic strategies, most of the strategies focus on caregiver response. Well, one thing is, are there triggers? I mentioned illusions where people see a robe on the door. If there are triggers, let's get rid of the triggers. If they always think a rock in the backyard is a bunny, let's get rid of the rock. Let's get rid of the robe. Let's put out night lights. Night lights create some shadows, but also create some more visual cues. Do they always see kids in the backyard at night? Let's close the windows. So get rid of any stimuli that might be triggering. And then there are a lot of strategies for caregivers. So if people like perseverate on an object, have an extra object. Don't argue with people. It is simply not helpful. You are not going to convince them. So we recommend a lot of distraction. If they're focused on something, distract them. Get them to think about something else. Don't argue. If it's a delusion centers around a caregiver, try to have someone who can come in and let the caregiver go out, because usually with time, it'll kind of pass. And so there are a number of these different caregiver strategies that we help them learn. And the Lewy Body Dementia Association has a really useful guide to behavioral symptoms online, and I print that and I hand that out a lot.
Yeah, that's a great resource. And I would say across a lot of different dementias, not arguing is a great piece of advice. But that's also a good resource, especially since typically LBD has some different behavioral things than like typical AD does. So I also had a question about the rates of comorbidity between LBD and AD, and what is the cognitive trajectory like in these patients compared to LBD alone? So kind of a mixed pathology.
Yeah, so in dementia with Lewy bodies, like I mentioned, about half of people will have comorbid amyloid pathology at least. I'm not aware of studies that, at least not a bulk of literature, that says how much of them have tau pathology. There are some studies, especially out of the Mayo group, Tanis Furman and others, but also out of some other groups now, that suggest that the trajectory does differ if you do or do not have amyloid pathology. So the clinical presentations will be a little bit different. Not surprisingly, you'll get more of a classic DLB picture if it's more of a pure DLB pathology. There are also some other differences. There are some studies that show that progression is faster if you have amyloid in addition to the DLB pathology. And it may also affect treatment response. There's some older literature suggesting that people with pure DLB pathology may respond more robustly to cholinesterase inhibitors, and people with dual DLB pathology respond, or DLB and amyloid respond less well to cholinesterase inhibitors. And in fact, it has so much implications for potentially for progression and treatment response, but that now there's pretty much a call that says if you're doing a DLB clinical trial, you have to get amyloid biomarkers, either CSF or amyloid PET. And in that Neflamapod study that I mentioned to you, where we have the preliminary results, they did find a difference between the group with and without amyloid biomarkers. The group without amyloid biomarkers responded more robustly, better to the Neflamapod, and the DLB group with positive amyloid biomarkers responded less well. So we know that co-pathology is going to affect presentation, progression, and response to treatment. And so that's a really important part of our clinical trials now.
Great, thank you. And we'll wrap up with this last question. You mentioned the 1 year rule between the motor symptoms and cognitive symptoms. And so can the 1 year rule be overlooked when the cognitive profile is most consistent with DLB, but the motor symptoms did indeed begin prior to the cognitive symptoms? Or like, how much flexibility is there?
Yeah, well, I mean, it all depends on what you're doing, right? Because so for a clinical trial, you have to have some rules about what box you're putting people in. And the neuropsychological profile between DLB and PD, cognitive impairment, there's a lot of overlap, more overlap than differences. I'm aware of 1 or 2 studies that suggest that there may be some differences between the DLB neuropsych profile and the PDD neuropsych profile, but there's certainly a lot of overlap. I will say, so it kind of depends on what you want to do with that information. What I would say is that if there is a prominent cognitive impairment, whether you call it DLB or PD with early dementia, the implications for progression are similar. In someone with a prominent cognitive impairment, a dementia, you are going to expect a more rapid disease trajectory than for someone who has Parkinson disease motor symptoms alone. I try to stick to the rules myself, because if we don't follow the rules, then our vocabulary doesn't mean anything, and the vocabulary is hard enough already. So I tend to stick to the definitions, but if someone came to me with Parkinson disease dementia and they were diagnosed with dementia 13 months after their PD diagnosis, so just over that 1 year cutoff, I'm going to counsel them that even though I may be calling them PD with dementia, I'm expecting a more rapid progression than someone who has had PD without dementia for 13 months. And so we are going to have those conversations. And that gets back to that first case. It's not just about what you call it, though what you call it matters. It's also about what you tell them about what to expect. So for that person, we're going to talk about how they're going to have more disability. They might progress quicker than the person in their support group who's had PD for 13 months and doesn't have any cognitive impairment. And they're going to probably respond less well to medication. And so I will counsel them in some ways that they're going to have a more DLB-ish experience, even if I'm calling them PD dementia. But there's a lot more to come on this vocabulary. I think the field is still evolving, so stay tuned.
That's a great point. Yeah, for sure. The vocabulary is always changing, and that's why it's good to have people like you to help inform us as it changes. So thank you so much for your presentation, and thank you everyone for joining. Please join us again next week, where we're going to talk about lifestyle strategies for promoting lifelong brain health. So we'll see you then. Thank you.